Right. Now, once again, thank you very much for joining this workshop. And we will have, inshallah, a fruitful discussion for next, let's say, nearly 3 hours. And in between, we would have some activities as well. And it's going to be a quite interactive session. You can interrupt me anytime. Please don't wait till the end. You can stop me anytime during the discussion, and we can sort out the issue before we move forward. So don't make it very formal. It's just mutual discussion. We are learning from each other. So if anything, just interrupt me, and we will discuss that point. Okay, now let me start with an opening statement, and which is very important. Direct observation of the medical trainee by an expert assessor and providing authentic feedback is considered an important tool for development of clinical and procedural skills. So the two components here, it's being claimed that if we want our medical trainees to have a good clinical and procedural skills, they should be observed directly while they are performing these tasks, and then a feedback should be given. So two components: direct observation and authentic feedback, which should be immediate. So this is a statement. And now question is that how this can be done. So what are different methods where we can observe directly and give feedback to the medical trainee immediately? You might want to share your experience. Can you think of any situation where we do this? We directly observe and we give feedback. If we are not doing, we can do it. Any ideas from anybody? Dr. Hassan Abdi, you want to share your opinion? Right. So one is, for example, we can have an OSCE. It's maybe a formative assessment, and we have an OSCE which comprises of, let's say, some clinical skills or some procedural skills, and we can observe the student directly, and we can give feedback immediately, right? The other methods which we are going to talk today is the mini-CEX and the DOPS, are directly observed procedural skills, are two important tools to observe the trainee during a clinical encounter or during a procedure to make an expert standardized observation. So the statement we just made that to train a medical student to have a good clinical skills, we should observe them performing those skills and then should give immediate feedback. And the different methods which can be used for this purpose, two of them is mini-CEX and directly observed procedural skills, where we can observe the trainee during a clinical encounter, and we can give, or an expert can give the feedback, and that would help the student to improve on their skills. And the good thing about both mini-CEX and DOPS is that it can be easily integrated into the routine work of clinical departments, means that we do not need special arrangements if we want to implement mini-CEX or directly observed procedural skills in our routine. So we can do it just in our routine work, in our inpatient or in our clinics or in our community, and so we don't need a special arrangement for that. And second is that it should be multiple encounters, let's say minimum of 6 to 8, so that this method is reliable. Less than this number, the mini-CEX encounters may not be reliable, right? So far is that our option or our desire is to have a direct observation of medical students performing certain skills or clinical examinations and giving them feedback. And that is best way to improve their clinical skills. And mini-CEX and DOPS are two methods apart from OSCE also, which can fulfill these requirements. However, we need multiple encounters to get a reliable result. So with this background, let's look at the learning outcomes, what we want to achieve in today's workshop. First is the participants will be able to explain the rationale for using mini-CEX in the assessment of medical students. Number two, discuss advantages of and challenges in using mini-CEX as an assessment tool. Third, compare mini-CEX with other tools of clinical assessment. And organize assessment program using mini-CEX as an adjunct assessment tool. So here I'm emphasizing that this is one of the adjunct assessment tool. It cannot be the only assessment tool. So it has to be added to other battery of tests. And then is conduct mini-CEX in their institution effectively and efficiently. So we are hoping that by the end of this presentation, the participants will be able to conduct these exercises in their institutions. Okay, now let's.
I have one question.
Yes, please.
Sorry. So you have mentioned that we need a minimum of 6 to 8 encounters.
Right.
So is this number of encounter minimum required with regard to a specific domain, for example, like history taking only? If we take example,
No, these
it
are
has to be taken six to
these
8
are
times,
overall.
or the other domains?
No, it's the overall. That doesn't mean
Overall.
that we have to have 6 in history taking and 6 in physical examination. No, it is overall. And
Okay.
later on, we will see that actually we can blueprint these encounters. So every encounter assesses a different domain. So means that we do not want that the same thing being assessed again and again. So if we blueprint, then we can cover a wider areas. Right? Okay.
Okay,
Now,
good.
now let's look at the mini-CEX, the concept itself. And I think snapshot is a very good description. This term of snapshot is a very good description of mini-CEX. It is a snapshot observation of a student. Either it's in performing a procedure or having an encounter with the patient, but it is in real authentic setting. It's not like OSCE is, for example, in a simulated environment, but mini-CEX is in a real authentic setting. It may be outpatient department, or it may be wards, or it may be community clinic, and it lasts, let's say, about 15 to 20 minutes. And the important thing is that the focus is on core clinical skills that a resident must demonstrate during clinical encounters. I think these 2-3 points are useful to remember. One is that it is a snapshot. It's just one sample, right? and it's about 15 to 20 minutes. And we are aiming at looking at the must know type of skills, our core clinical skills, when we are talking about mini-CEX. And the other is that in this exercise, a single assessor, only one examiner observes and evaluate students, but it is very focused, a focused history taking and focused physical examination. So this is another attribute. So one, it is a sample of a candidate's performance, which is, let's say, 50 to 20 minutes. Usually we are looking at the core clinical skills, and these are very focused. They are not generalized. These are, so whatever skill or procedure we are observing is very, very focused, is very well defined. Right, now I'm next 3 or 4 slides, I'm going to talk about the historical background. And the reason I want to do that is that it would explain us the rationale, why we want to use mini-CEX, or why different institutions are using mini-CEX. So that would explain in next few slides. So it started with the American Board of Internal Medicine, and for their first 40 years of existence, they were using the traditional bedside examinations, the traditional bedside oral examination for assessment of the certification process. So for 40 years, they were using that. But then they found by 1972, that there are thousands of doctors they need to assess annually. And to do these traditional bedside oral examinations to assess these thousands of doctors was really becoming difficult. Logistically, it was becoming difficult. So what happened is that at that time in 1972, the board recommended to assess the clinical competence of candidates for certification by using a clinical evaluation exercise. So the first thing why the clinical evaluation exercise came, because the long case which was being used was logistically becoming difficult. So a new approach was adopted, which was clinical evaluation exercise. And basically, it is same. It was same like bedside oral examination, but it was one case and single examiner, whereas originally either there were multiple cases being examined or there were multiple examiners. To reduce the workload, so the board decided to use one bedside long case examination, and that would be observed by a single examiner. So a single faculty member evaluated the trainee as he or she performed a complete history and physical examination on a pre-selected patient in the hospital. So it was like original long case, but in this case was only one long case and one examiner. But like traditional long case, the patient was pre-selected, but rest of the components being assessed were same. The trainee were then expected to come up with a diagnosis and the management plans, and then they need to present their findings. The additional thing was that apart from presentation of long case, the candidate was expected to produce a written report of the patient so that it is kept in the record of that student. And like any long case, the faculty member would assess the trainee in along with several dimensions. So this clinical evaluation exercise was a 2 hours exercise. So one student, one examiner, one patient, and 2 hours of assessment. So in a way, although it was just one case, but was quite extensive exercise, still an extensive exercise. The So once this clinical evaluation exercise was introduced, so people started to evaluate, and then it was realized that this assessment cannot be generalized because the sample size is too small. And that is also a problem with the traditional long case, that if the we cannot generalize the results from one long case to other areas. For example, if a student has performed well in examination of abdomen, we cannot assume that student would be good in performing, let's say, CNS examination as well. So because the sample size is too small and it is not cannot be generalized. So that was the drawback which was found in this clinical evaluation exercise. So this is one example of the publications which came out about this issue about clinical evaluation exercise and the inability to generalize its results. So then mini-CEX was a response to some of the shortcomings of clinical evaluation exercise because the major issue with clinical evaluation exercise was that although it's a 2-hour assessment with one patient, but the big limitation was that the ability or assessment cannot be generalized. So to address those problems, the concept of mini-CEX was introduced. And it was based on the educational interactions faculty routinely have with trainees during teaching rounds. So to make it more easy logistically, it was designed in such a way that becomes a routine work or workplace based activities, and there's no special arrangement needed to implement that. So in this case, as in the clinical evaluation exercise, one faculty member observes a trainee patient encounter or a procedure. However, the counter is focused, lasts roughly 15 minutes, and several encounters are included in the overall assessment of a trainee over a period of time, maybe let's say 1 year. So because of the major issue of clinical evaluation exercise of sample size, only one encounter. So this was introduced that we should have a minimum of 6 to 8 encounters to have a reasonable sample size to get a reliable result. If you see, let's say the 2 hours of clinical evaluation exercise, and if you divide it into, let's say, in 15 minutes, so it becomes about 6 cases. Although that's not the reason for making 6 cases, but I was just thinking that it actually amounts to the same duration, although at different occasions. So these encounters, because there are multiple encounters, so there is a broader range of challenges that in a variety of settings. So we can see now with the, let's say, 6 to 8 encounters of 15 to 20 minutes each, every time a different patient maybe a different examiner and a different domain. So that gives a quite broad range of challenges that can be presented to the students and assessed. The fact that several encounters are observed increases the quality of both the assessment and the educational feedback. So it becomes more authentic. It also offers the opportunity to include different faculty members. So all the 6 encounters may be different, 6 different examiners. So what would be actually that 6 different cases, 6 different examiners, 6 different domains. So in this way, mini-CEX becomes quite broad a range of assessment, and that improves the reliability, which was a major issue with the clinical evaluation exercise. So that can be addressed by introducing mini-CEX. So now, having that background, so we can say that mini-CEX is a method for simultaneously assessing clinical skills of trainees and offering them feedback on their performance. So these are 2 important components of any mini-CEX, that we observe either the clinical skills or procedural skills, and then we provide the feedback. Basically, if you look at it, it is a miniature form of a traditional long case. It is a simple modification of the traditional bedside oral examination, and because of that, it relies on the use of real patient and the judgments of skilled clinical educators. So basically, it's a smaller version of a traditional long case. Although we can assess different aspects of a case in different encounters. Right. Now, that was to understand why the mini-CEX was introduced and what is its rationale for use, and how we can overcome the issues we were having with the traditional long case, especially in terms of reliability. So the next aspect we are going to talk about is that what kind of competencies can be assessed in mini-CEX. So originally, when the mini-CEX was introduced, it was composed of 4 competency domains: the history taking, physical examination, clinical judgment, and humanistic qualities. 4: history taking, physical examination, making a diagnosis, and planning the treatment, as well as the soft skills. So that was the beginning of diagnosis that was the beginning of the mini-CEX. However, later on, the American Board of Internal Medicine, they revised these domains, and they came up with 6 different domains, which was interviewing skills, which is the history taking, physical examination, the professionalism, and then the clinical judgment, counseling, and organization. So there were some additions in the competency domains. And then again, further, some other institutions introduced some more domains, other competency domains, and that included technical and procedural skills. So initially it was the clinical skills, but then the procedures and technical skills came into. Then is the counseling, patient counseling, and the education, risk management, documentation, and team interaction. So actually, you see the domains, the competency domains, which can be assessed in mini-CEX, their number increased over time. And now we know that we can assess the history taking, we can assess physical examination, we can assess the professionalism or human qualities, clinical judgment, clinical reasoning, making a diagnosis, counseling, patient education, organization or efficiency, that how the student uses the available resources effectively and efficiently, technical and procedural skills, documentation, for example, referral letter, discharge slips, writing a prescription, etc. So these can also be assessed. And then teamwork, working with other health workers, and the overall clinical competence. So these are the list of competencies being assessed in mini-CEX. However, one should realize that we cannot assess all these competencies in one encounter. So all competencies may not need to be tested during each counter, and choice can be made depending upon the case and seniority of the students. So if we do the blueprinting properly, we can divide these competencies over a number of cases and tailor it to the case we are assessing, and also, of course, whether it's a third-year student or is it a final year student, maybe the history taking during early residency and the counseling skills can be assessed during later part. So we can spread these competency domains over different cases. Here is an example from Brigham Health Education, and they have divided the domains under different disciplines. For example, in medicine, they said they will be doing history and physical examination. In surgery, post-op evaluation and creation of treatment plan. In obstetric, maybe examination of pregnant patient, and so on. So basically, this is an example which can illustrate that we can spread over the competency domains among different disciplines on different cases. Right. Now, next is the rating skills. Any questions so far? Any comment or question? Any person want to?
Hello, sir.
Yes. Yes.
This is Dr. Murli from MUCM, Manipal University College, Malaysia.
Yes, sir.
I have a question, sir.
Yes.
So in your introduction, you were saying about we should always use a must-know topic. So far, always for the students, we are asking must-know topics only in OSCE, in SAQ, in MEQ. Why should we always depend on the must-know topics only? Good to know topics also can be included, because if they come across these sort of situations in their clinical practice, then how can they handle it?
Right. You are very right in that. But sir, what the concept here is that this is an exit examination, and we want to produce the safe doctors. That is the minimum requirement. Now, if you see although we are saying the core and must know, but there are always questions where we do the discrimination between the let's say very good student and let's say an average student. The reason we emphasize it again more and more on core is that the core should not be missed. Any student should not graduate without fulfilling the core aspect. Otherwise, you are absolutely right. That doesn't mean that we do not want our students to excel. There would always be the opportunities during the assessment. Let's say later on, we will see the rubrics, and that would help us to differentiate between an average student and a good student. But basically, the emphasis is that no student should graduate without having must know or minimal requirement of clinical skills. But I do agree with your point that the examination has to cater for all kinds of students.
Yes,
Assalamualaikum,
but
sir. So can I add to this comment that you've just given?
Yeah, yes.
one more minute, madam. One more. I'll give a little bit of another hint to this, because when we give the logbook or the handbook to the students, they very well know that in the curriculum the must-know topics are being listed out. So they
Right.
come across and they study only the must-know topics and they come for the exam. So they will never have an interest into the good-to-know topics or other topics. So in my opinion, we have to include a wide range of topics to them. They should not know that it should be asked only in the must-know topics.
Yes, let's see what Dr. Aisha has to say, and then we can discuss it further. Yes, Dr. Aisha.
Sir, with regard to having just focusing on the core or giving some topics other than that, it depends on the institutional policy that how much of percentage is allocated to other topics. So in certain areas, we allocate 10%. In others, we allocate 20% of topic that would be non-core. So it depends on the overall blueprint of the exam. But in modalities like mini-CEX, in which although the frequency is more than the long case, but it is still less than the other comparable exams like OSCE. So in which we have already a compromised number of encounters that we can have, then we have to ensure that at least the core is covered. That is why for the workplace-based assessment, we focus mainly on the core competencies. But you can, again, it depends on the institution that if they decide that 10% needs to be allocated to other areas, they can do that.
Normally, Dr. Murali, if you see the distribution of the assessment, for example, the questions is in a curve, where of course the highest number would be in the middle, but there would be some questions on both extremes as well. So, and like Dr. Aisha said, that when we are talking about specifically for this mini-CEX, and the number is let's say maximum 6 to 8. So in that, we of course we would have rubrics for let's say average student and a better student, and they would get might get different assessment. But we want to make sure that the core or most important or must know areas must be assessed during these sessions. As I said in the very beginning, that this is an adjunct to the assessment. This is not the only assessment we are going to do. So we would have opportunities in other modalities to let's say cater for different level of students. This is not the only one examination we are going to do. This is just one of the different methods.
Okay, sir. Understood. Okay. Thank you.
Any other questions? Any other comments? Okay.
So one comment, one question I had, sir.
Right.
It is comparable to the long case, we understand, and the domains of assessment that are included in it are also the same as we had in long case. Then where have we shortened it? Where is the meaning in it?
The meaning is in number, the number of encounters, because like said in the beginning, that if we do one long case, we cannot generalize the result. But if
I understand that, sir.
Yeah.
With regard to the time, like in long case, we would have at least 1 hour, but now in mini-CEX it's 15 to 20 minutes. Now,
right,
how all the domains that they were there in the long case are covered in a mini-CEX, but they could not be covered in the long case. My query was that were we overdoing it in the long case?
no, they basically we are assessing the same domains which we assess in a long case, but now we are doing it more frequently, and that the reason is to give it a reliable result. You see, I have another suggestion which I gave to my institution as well. Now, for example, in our final year or 5th year, we have 5 or 6 postings. And if we are doing a long case at the end of each posting, so this means that before they come up to the final year exams, they have already done 5 or 6 long cases. In our long case, we in final professional examination, what we use is what is called the comprehensive, means that you would have only one long case, and that would be the student would pick up the lots, and so one student may get a medical case, another surgical or ONG. So because to do the traditional long case in every discipline now is logistically very, very difficult. So, but if we include our end of posting long cases in our final assessment, means that the end of posting long cases are contributing to the final professional examination. And then we can say that we have enough sample size. We have 6 or 7 long cases, and we can say that the sample size is good, and we can generalize, as long as we make sure that we are not repeating the same thing in every long case. So that is one. The long case is definitely much better than the mini-CEX. As I said, the mini-CEX is a miniature of traditional long case. But the only issue with long case is that the sample size is very, very small, and it's very difficult to generalize the result. So mini-CEX can address that. Right? Any other comments? Any other questions? Okay, let's look at the after going through what kind of competencies can be assessed in mini-CEX. Let's look at the rating scales which are used in mini-CEX. To begin with, it was a 9-point Likert scale for rating each competency domains. So first 3 was unsatisfactory, then is the marginal, 4th is marginal, and satisfactory is 5 and 6, and superior performance is 7, 8, and 9. We should realize that this is an subjective assessment. There is no checklist. So this is the sort of impression of the expert assessor or examiner, and first they decide whether it's a satisfactory or unsatisfactory performance, and if it is satisfactory, whether it's at what level, or it's a superior performance at let's say distinction. We say, okay, this student is has performed more than satisfactory and goes into the distinction area. And here, the question which Dr. Murali was raising about the assessment of good students. So here in this assessment, the difference between average and good student would be addressed. Although it is a core, still a core area, but the performance of students in core area, whether it is just satisfactory or it is a superior performance. So that was to begin with the rating scale. And later on, the two more terms, one more term was used, either not observed or insufficient contact, because as I mentioned that one, let's say, encounter may not address all the domains which we want to assess. There were some modifications, and another suggestion was instead of 9, using 6-point scale, where 1 and 2 are below expectations, 3 is borderline, 4 meets the expectations, and then is above expectations. But most of all, I was really impressed by this thought to use the interestment scale as the rating scale. So rather than saying satisfactory or unsatisfactory, here is that if we think of those encounters as interestable professional activities, and then we rate the student whether what kind of further supervision the student needs. So it was, I think, quite interesting thought that rather than using satisfactory, unsatisfactory, or we use the scales like this, that student need improvement or meets expectations or exceeds expectations, and then whether it was not observed. So this was another approach which was initiated in the National University of Singapore. And then after this, let's look at the different kind of forms which are used to assess the students during these encounters. And what happens is that after the task is complete, whether it's a clinical skill or it's a procedural skill, the faculty member completes a short evaluation form and gives feedback to the student. As mentioned earlier, that in mini-CEX, we use a global rating and subjective expert rather than a checklist, although we have rubrics, but it is the subjective assessment. And the results are recorded on a generic form. The form also records the student's identification data. And important is the complexity of the case, right? So that and the site where the encounter was held. So normally what would happen if it's a case is complex, usually the assessor would give some allowance to the student about that case or situation. The form also lists the details of competencies and their brief description to provide guidance in evaluation. Means that some kind of rubrics is provided. So here we have these 3 examples here: American Board of Internal Medicine, and the Royal College of Physicians, and the National Collaborative Prescribing Program, which is based on interestment base. I'll send.
Can I ask one question?
Yes, please.
Okay, thank you. With regard to the rating scales,
right?
Can we use this rating scale also to give grades in the final point? Like if that's the case, how can we convert these rating scales into the grades in number?
Right. Now, there are 2 aspects. One is if we are using for formative assessment only, then obviously we cannot use that in the summative assessment. But if we are using it as a component of continuous assessment, as a part of summative assessment, then of course we have to convert it into some kind of score. So in that case, if we use that 6-point or 9-point Likert scale, so that can be converted into the marks, but the entrustment form would not be able, we would not be able to convert that. So entrustment form is mainly for formative assessment. But let's say American Board of Internal Medicine or Royal College of Australian, there can be converted into the marks. Basically, we are going to do an activity. I'm going to share all these 3 forms with all of you in the WhatsApp group. And then our first activity is going to be to design our own assessment form. So I think that in couple of after a couple of slides we would be doing that. Right now, this is the one form. I think this is American Board of Internal Medicine, and you can see that it gives all the information here about the setting, whether ambulatory, inpatient, or other. About the information about the patient, the complexity of the case, and the what is really focus of this encounter, and then is the 9-point Likert scale, right? So this is one form. This is the one I was talking about, based on the EPAs. And where now here, if you see, the assessment is needs improvement, meets expectations, or exceeds expectations and not observed. So this is mainly for formative. And obviously, when we say, let's say the comment is needs improvement, then assessor would write the points, the areas where the improvement is needed, because at the end of the session, there has to be a plan and for future action, and both examiner and student has to agree on that. All right. So like here, say areas of strength, areas for development to be completed by the assessor, and then agreed learning goals for next assessment to be completed by the student. So so plan is there, and that's one positive thing about mini-CEX is that over time we can see the improvement in the level of students and whether they have met the requirements. So now we are going to have an activity, and the first is to design a mini-CEX assessment form, and you can now choose competencies which you want based on your requirement, your region's requirement, and just make a quick, simple form. I'm going to share the 3 forms in the WhatsApp group, so that you can use that as an example. And also, I will divide all the participants into 3 groups, so you can work in the groups. Right now, first I'll send the forms, and you can go through the form while I'm dividing you in different groups. Right. Can you hear me?
Yes, sir.
All right. Okay. Now, I hope you were able to discuss and frame some questions. Maybe can I ask Dr. Isma? Dr. Isma Ahmad. So
Yes,
let's see what issues you think your group mentioned. Everybody can switch on your camera, please. Please switch on your camera.
Okay.
Okay, let's say Dr. Isma, your group. What were
Yes.
yes, what issues you thought you might face?
And mostly the issues that I may face is feedback, how to do feedback to the students that you are assessing.
Right. So that's so your group feels that you may not be able to give the feedback,
Yes.
right? Okay.
Also, it's good to improve the quantity and also to the quality of doing feedback to the students.
Right. Let's see what other people think about it. Dr. Fried Mohsen, how would you address that? Let's say some Dr. Isma says that they find it difficult. They are finding it difficult how to give feedback. So what you can
Yes, sir.
suggest?
First of all, sir, it is multiple interaction around 6 to 8 times you told us, and it is a
Right.
formative assessment. So that is not easy to accomplish.
Right.
Say, and second is like feedback. So we have to train the faculty how to give feedback.
Absolutely right. Yes.
Same thing. So these two obstacles, I would say
Right.
that.
Okay. Now, Dr. Isma, giving feedback is a skill. And like Dr. Farid mentioned, that we need to train faculty how to give feedback. It is very important that the right approach is adopted and right words are chosen. It's a very, very careful exercise, and you need to do some practice on that. The first thing is that we reinforce or we pick up the positive point. We always start with the positive point and appreciate that you have done this component very well, right? And then we come up with that these are certain areas where you need some improvement. And so we identify those areas, and then we give suggestions that how to improve on those areas. And in the later on, the student has to, and when you draw the plan, the student has to work on that. So if we follow the route, the protocol which I have just mentioned, first we ask the student himself or herself, what do you think which areas you have done very well? What you think are the areas you need improvement? And how you think you can improve? So let the student speak out first and list down these things. And then you can find out whether you agree with the student. Maybe the area which student thinks that he has done very well, in your opinion, that may not have been done very well. So it tactfully, we have to communicate with the patient, not with the patient, with the student in that area. So you may need a little bit training in that. In medical education overall, feedback is a very, very important area where we need to learn. Right? Anybody has any additional comment to that? Dr. Said Ali, you have some opinion on that?
And that's good thing to ask the trainee how he's feeling or the area that he need improve. So I agree with that, Professor. Thank you.
Yeah, I think that's something very good, because that gives you insight as well, that how student is thinking.
Absolutely, yes.
Then you may either agree or disagree, but when you disagree, you give your reasons. For example, student tells me that he has the task is to palpate the spleen, and student says that he has exactly find out the spleen. He might have find out, but the technique may not be the right. So sometimes by chance you can make a right finding, but your technique may not be perfect. So you can say, okay, yes, you have found the spleen. It is 3 centimeters, absolutely right. But you need to improve your the palpation skill, because you may not find these things every time by chance. So in this way, we have to be quite positively critical and guide the student. Right?
Sir, one quick question.
Yes, please.
This like we asked the student that which domain he has done well, on where is his deficiency. We have to ask it after giving feedback or before?
No, before feedback. Once we start feedback, we start with this.
Okay, we start.
We start with this. We ask the student, what do you think? How was your performance? I remember now one of my students that was on written paper, and I just asked him, how was your written paper? And he said he has done very well. But when I looked at the paper, there was hardly anything in the paper. So
same thing we experience also, sir.
yeah, so sometimes there is sort of confidence which is based on the false assumptions. So we have to be very, very critical. Like I gave the example of spleen. Yeah, sometimes we may find the right thing, but that was just by chance. The technique, the process is very important, and we need to emphasize on that. Okay, Dr. Isman, I think we have answered your question.
Oh, yes, doctor, thank you.
Right, okay. The other group, Dr. Ishrat. Is Dr. Ishrat here? Yeah. Okay, maybe we, Dr. Hassan Abdi. Yeah. You were mentioning something.
Yes, we have mentioned a time for assessment.
Sorry?
We have the time, the limit of the time. Time is limited on assessment.
Yeah, is it that you were mentioning that the number of students and the number of staff?
Yes.
All right.
There's unequal, yes.
Basically, this is best done in the rotation.
Okay.
Let's say you might have 150 students, but then there are 5 or 6 rotations. So every rotation there would be about 30 students. So you cannot do it at the end of the year with 150 students, but you can do it very easily during a rotation. For example, in medical rotation or surgical or IE or ENT. So within that rotation, you can do it, this mini-CEX. Maybe if there are 30 students and there are 3 or 4 staffs, you can do it over 3-4 days time. But it is manageable only during the rotation. At the end of the year, doing 150 students would not be possible. And because we want to do it over the time, over the year, and we want to see how the student progress. So it is best done during the rotations, mainly the clinical rotations.
Okay.
Right. Okay. Dr. Jamila, you have any opinions, any questions, comments?
Yes, the group actually find that maybe the ratio of the student to the staff for undergraduate might be quite a challenge. Postgraduate is not that bad. And in some of the institute as well, with limited number of the student, it could be that might not be a challenge. But another big challenge is that according to the specialty, like in dentistry, that's quite difficult to perform because they do perform. You have to see them perform so that you give the feedback.
Right.
So but the whole idea might be adaptable. Yani we can think of how can we utilize such a beautiful assessment tool in dentistry. I'm just thinking how could it be modified so that it suit the dental specialty.
You see, if I understand right, dentistry is mainly hands-on, practical things.
Both, but mainly practical. Yes.
Yeah. So
and
and
we do observe and give the feedback directly, yani on a specific case,
right.
on a specific specialty. It is not. It's more of the way I see it. It's more of a manual skills in dentistry.
But,
in addition to the mental exercise and cognitive.
This means that in one way or the other, you are already doing it.
More or less, yes. But now with this workshop, it gave quite few ideas of how can utilize it with more than one thing.
Right.
Like the procedure itself.
Yeah.
How can we divide it so that we are covering the examination, and then we are covering the procedure itself. We are covering the communication skills. These could be like a mini event. Yeah.
I think you are absolutely right. You are absolutely right. And the practicality is that this can be a part of routine work.
Yes.
Yeah, rather than having a special examination, this can be a part of routine work. That is one strength of mini-CEX, that you don't need special arrangements for that.
Especially with
maybe just at the end of the ward round, you pick up one student and okay, now we are going to do that for next 15-20 minutes. And you don't have to prepare anything.
Preparation of specific form, that sounds like quite a useful thing for both the student and to decrease the subjectivity as much as possible, I think.
Right. Yes, absolutely right. So if once we have made our generic form, then it can be just a routine activity. Like I said that, okay, the last patient on the ward round, or maybe the next patient in outpatient. Yeah. So just make it a routine rather than having a feel burden. Rather than feeling a burden, can incorporate in the routine work.
Yes. And probably other specialties as well can think of it. It doesn't have to be only dentistry, probably pharmacy, allied health sciences. I think there must be a place for it.
All right. Dr. Qasim, your opinion, please.
Sir, regarding the feedback, you have already mentioned this, but I just want to highlight one thing that you mentioned that. So you already mentioned that why it is important to ask the students
right
what they have done and what do they think has gone right and what has gone wrong.
Right.
I feel that it is very important because it will give us the idea about their cognitive process, and whatever they are doing, it stems out of their thought process.
That's right.
It is very important to get into their thought process, because if we will not identify that, we will not able to rectify, or we will not be able to help them to rectify that
Absolutely
mistake.
Right. Absolutely. Yes.
And one thing which I want to highlight, there is another methodology. You have mentioned Pendleton's process or method of giving feedback. There is another process. There is another method which I was doing. I was studying medical education. We studied about the debriefing with good judgment.
Right.
So I also want to highlight that by Randall, that whenever you are giving the feedback, you should, as you mentioned, that we should give the positive.
Right.
We should always be positive. So
Right.
that is what the crux of that model. That whenever you are asking the student, you should be thinking positively,
Yeah.
and you should try to judge the student in a good way. Yeah.
Absolutely right. And the one
Yeah,
point
yeah.
which you mentioned is that asking the student, sometimes student may have a false confidence. They may
Yeah.
think that they have done this right and that's the right way, but unfortunately that may not be the right way. So it's very important that we actually address that. Dr. Murali, your opinions, please.
Hello.
Yes, sir.
Sir, in my opinion, I think there are two other challenges can be faced
Right.
depending on the variety of cases and the shortage of cases also.
Right.
I think you are also in Malaysia. We usually come across in general surgery more of abdominal cases than the vascular or some sort of any lumps and bumps. I think that sort is out here.
Right.
That's also a problem. Next is that lack of faculty training for this sort of new methods of assessing the students. Probably the faculty development program should be initiated to take more effort into the training part given to the faculty members who are literally involved in the curriculum as such.
Right.
That's my
Okay. The first is the type of cases. Obviously, we have to address the core. So, in your logbook, what are the, let's say, must-know cases that should make the part of this assessment? And second, I have been reading about it and doing it. Actually, the training in this is not very difficult. Most part of it, we are doing it in one way or the other, although not formalized. We do observe students examining patients, and we do help them to improve their technique, give feedback as well. This is just to formalize that. And even just one workshop with the staff members may be good enough to train, because hardly there is anything new. Most of the things we are familiar with. Only thing I think would be difficult would be to agree to a assessment form. Once we have made an assessment form, then I don't think it would be a big challenge.
Okay, sir. Okay, understood.
Right. Dr. Ishrat, you have something to say? Okay. Right. I have few more things to share before we conclude this session. Let me go to that. Is the screen visible to everybody?
Yes, sir.
All right.
Yes, sir. Visible.
Okay.
Visible.
Now let's going to the last part of this session. Is the training of assessors, and that's what exactly we were just talking about. So, as I said, simply one workshop or a discussion among the staff members would be good enough once we have agreed to an assessment form. So it shouldn't take really much of effort in training the staff about it. Right, and the areas which we need to focus in training is to reduce the common errors, means not being too strict or not too lenient. The main idea would be basically helping the student to identify the areas which need improvement and then guiding them how to improve on those areas. So that would be the one focus, means the identify the weaknesses and give a suggestion how to improve on that weakness. Second would be understanding the dimensions being assessed and the standard of assessment. Dimension means what domains we are going to assess. And standard of assessment means what should be our standard for year 3, for example, or year 4 or year 5. And the accuracy of ratings. And the next would be improving the detection and recall of performance, means that because we have to write a report on that. So the ability to note the important point and then give reporting on that so that we get the maximum benefit. So when we are planning to train the staff, these are the four areas which should be addressed in any of these training sessions. It can be a written guideline or online guideline, or it can be a presentation or interactive workshop, or maybe video-based materials. So the point I'm trying to raise is that you really don't need an extensive training. If we, for example, you have a video available on that, you can share a video with everybody, and that might serve the purpose. The training in rubrics, that would be the most important part, and generic training, and that need to be repeated when the new staff members come. Yeah. So here is an example of rubrics. For example, history taking. If we say the more than satisfactory, a comprehensive biopsychological history is taken from the patient. All available sources of information are appropriately considered when taking history. If you search in the net, you will find many documents about these rubrics, and you can actually like this one. You can, and then you can modify them according to your situation. So that can save a lot of time and effort. For example, you pick up something like this, and then you modify it according to your situation. You can discuss at your department level and come up with a final document on that. So that was training of assessors. So again, we need to have a little training about the students also, that they should know how it is being conducted, what are the points being assessed, and how the assessment is done. So that would help the students to prepare better for this assessment. And if we have done it in undergraduate, it would become so easy to do it in the postgraduate level. Now, what happens with the results means the assessment report, each of the rating form is returned to the central location. So all this information is, let's say we have an exam division, and so all the reports would go to the exam division and go into the student file, and all the data would be entered in the computer. Because once we have all these 6 encounters, you can see how the student has progressed over the time. And it should not be looking at only at the end of the year, but let's say in between the encounters, that what advice was given to the student in the first encounter, and whether that issue was still there during the second encounter, our student has improved on that. So it would be a kind of continuous monitoring. The educational supervisor will discuss the feedback with the trainee. If student is not really picking up, the either supervisor or a mentor can discuss with the student about the progress. And of course, if we decide that these encounters are contributing to the final assessment as a part of continuous assessment, so especially the rubrics, based on the rubrics, the results can be converted into marks with, of course, with the discussion with the faculty, and it can contribute to the final exam assessment. Now, just few slides on this to see how mini-CEX itself is evaluated. So one way of assessing any assessment tool is what is called the utility formula. Means that any assessment tool, we want to look at their validity, their reliability, their educational impact, acceptability, and cost of assessment tool. So these 5 points are really, really useful. Whatever method of assessment you have, you can evaluate that method, whether it is valid, whether it is reliable, what is the educational impact, whether it's acceptable, and whether it's cost effective. Of course, this the mini-CEX is very valid because it is being, you are observing that you have a focus, and you this is very focused, and you already know that what you are going to assess in that encounter. So it should be valid. It is reliable because we have multiple encounters, let's say multiple encounters and multiple assessors, multiple patients. So so it becomes very reliable. Let's say 6 different patients, 6 different encounters, and 6 different examiners giving an opinion. So that overall it becomes quite educational, reliable exercise. Educational impact, of course, is that whenever we are giving the feedback and the student is going through this helps the students to improve and to identify the areas which need to be addressed, and so it would have a quite robust educational impact. Acceptability, the literature shows that it's quite, especially very popular among students, because this is a formative assessment mainly, and they get feedback. They get a plan and action plan, and it helps them as well. And as compared to, let's say, long case, the examiners find it acceptable as well, because these are the small encounters, and it is part of routine activity. They don't have to organize special exams for that. And cost, because in fact, there is hardly any cost involved in that, because this is a routine activity, and you are not making any special arrangements for that. So if we follow this, the utility formula from all these 5 points, this mini-CEX actually fulfills the most of the requirements of a good assessment, mainly the formative assessment, but that can also become a part of continuous assessment and contribute to the final exams as well. So this is the summary of the next few slides, which are included here. So another point in this utility formula is that the key point of this notion is that an assessment low on one of the attributes can still be useful by virtue of being high on others. So it means that we mentioned earlier as well that not all the domains can be assessed in one encounter. So in one encounter, some domains may be assessed very well, others cannot be assessed very well. So we should not be looking for a situation where we want to assess all the domains in one patient. In fact, these encounters would actually help each other, or they add to one another. So what a deficiency in one encounter will be covered in the subsequent encounters. So that should be our approach in this. So I have mentioned about the reliability, and the validity, yeah, because important instrument for direct observation of clinical performance. Acceptability, even the papers, the publications show that it is acceptable assessment even in the emergency department. The students can be assessed even in accident and emergency department, and it is acceptable and as well as reliable. Educational impact, as I mentioned, the observation and feedback is the major driver for educational impact. In feasibility, like mentioned, that it is a routine activity, so you don't have to make any special arrangements. So overall utility, mini-CEX is found to be a fairly valid and feasible assessment strategy for clinical skills, justifying its use for both undergraduate and postgraduate education. That means that I'm not denying that you will have some hiccups here and there, but I think they are not major issues, and with little bit effort, all those issues can be addressed. This is basically to show the comparison between a long case here and a mini-CEX here, and you can see their comparison, and the reliability is comparable. So looking at the assessment, looking at the occasion, looking at the task, the time, the basics of assessment, so it is quite comparable. And the good thing about mini-CEX is that it can be integrated into the daily activities. This is another study which shows that once the mini-CEX was introduced into the daily activities, the results of the students become, especially in OSCE, became a lot better. So the pre-intervention, it was 12% failure, and post-intervention, it was just 2% failure. So even if we are using OSCE as a final assessment, the introduction of mini-CEX in our routine activities would help students to perform better in OSCE, and their pass rate would be high. So indirectly, it actually helps in their performance during OSCE. The assessment of relationship between the mini-CEX scores and the results of well-established examinations has been shown that the mini-CEX scores are actually in line with, or correlate very well with the standard examinations. So in that way, it is valid and reliable. The OSCE traditional clinical examination family or internal medicine, standardized patient exam and clinical skill exam, they all were very, very well correlated. So that means that mini-CEX can in a way predict the overall performance of the student in different other methods of assessment. Challenges, we have mentioned some of them. The trainee's performance with one patient is, of course, not sufficient. So having multiple different occasions would improve the reliability. The training of assessor is helpful. We have already mentioned that it's not really a big task to train the assessors, and that can improve the reliability and validity and overall performance. So in conclusion, the mini-CEX is widely used as a formative and summative assessment tool and appears to have reasonable validity and reliability. The reported acceptability and feasibility should be interpreted in the light of required number of encounters, means minimum of 6 encounters. And by providing a framework for structured observation and feedback, the mini-CEX bears a favorable educational impact. So that is the overall conclusion of our the studies on mini-CEX. So I would be happy to answer if you have any more questions.
I have one question.
Yes, please.
Sir, how can we regarding reliability and validity, how
Right.
can we convert it into numerical value? Like when I'm talking in relation to the quality requirements.
Right.
So whenever we have a quality visit, they will ask us the solid thing or
Yeah,
how.
I think for that you need the statistical help. Basically the statistic department need to help you in looking at the result and, let's say, comparing the results of mini-CEX with the other methods of assessment. Let's say comparing with long case or comparing with short case or comparing with OSCE, and then looking at the number of encounters. So basically the values can be deducted by applying different statistical methods, which I'm afraid I'm very poor in that.
Yeah, so no, I'm just for the sake of like knowledge, because you know that for the MCQs we have a certain method.
Right.
For SCQs we have a certain method. So
Right.
in literature, like individually, you are talking about comparison. So if we want to specifically determine the reliability and validity statistically of the mini-CEX,
Right.
is there any literature on that? Not the comparison, like individually.
Yeah, there is. Now, Dr. Qasim, what you are mentioning, there are two different things. For example, MCQ is objective, right? Objective assessment. OSCE is objective assessment, whereas the mini-CEX is subjective, right? Now, if you compare the assessment of mini-CEX with OSCE, and if they correlate very well, so this means that although it was subjective, but it has correlated very well with an objective method, isn't it? Yeah, so that's the basic difference. If we can show that our subjective assessment is as good as the objective, that gives a lot of strength to this method of assessment. So actually, you can do this small study in your own institution. You can conduct this, let's say, after a little bit training of students, you can conduct this mini-CEX and then make an assessment and compare them with any other objective. I mean, it has to be if it is clinical, it has to be compared with clinical objective, which would be, for example, OSCE, or your short case, or your, but basically short case, long case are also have a lot of subjectivity, but OSCE is very, very objective. So if you can compare your assessment of the mini-CEX with OSCE, and if you find it comparable, that means it's really, really useful. But if it is not, then means that we probably need some improvement in our mini-OSCE. Mini-CEX means the something is wrong somewhere. So we need to address that. I think that could be a good exercise.
All right, sir.
Right.
Thank you.
Yeah. Any other comment by?
Sir, can I just
Yeah,
add to what
sure,
you've
Dr.
already
Asha. Yes.
said? One thing about what Dr. Qasim had mentioned with regard to that, most of the rubrics, they give a comparable numeric value, and we deal with it as we deal with all rating scales. The basic statistics are the same. The reliability that we calculate is also the same as we do with other rating scales. So nothing specific with regard to that. So, but if the rubric is developed in a qualitative manner and there are no comparable numbers, we would first have to do an exercise of agreeing on what comparable numerical values can we give to that rubric. And the second point was, sir, with regard to the point that was raised with the practice of dentistry or other surgical fields. Today we were discussing mini-CEX, which relates to clinical skills. There are other workplace-based assessment tools which we have not discussed today, and maybe inshallah in future workshops you would enlighten it with that. And like DOPS and USETs, which would be very much relevant to dentistry and other surgical fields.
That's right. That's right. Yeah. The directly observed procedural skills. Yes. Yeah. That actually very close to mini-CEX, but that would be mainly looking at the procedures, and that then your rubrics may be different, and your domains of assessment might be slightly different. Right? Any other comment by any of the members? If none, I really, really thank you for your support, and the going through all the sessions is almost 3 hours. We have been discussing this, and really good thing would be that if each one of us should try to do something about it, and then you can share your experience. Those of the participants who were not previously in our MedEd group, with your permission, I will add your name to the MedEd webinar and workshop groups, and then please keep on sharing your experiences with. If once you write in the group, everybody would read it, and in that way we can help each other in this noble task. Right. Thank you very much, everybody.
Thank you, sir.
Because at least I enjoyed the session. I hopefully you also enjoyed the session, and at the end of the day, we get something good out of it. Thank you very much.
Thank you, sir.
Thank you.